Hello, everyone. Nice to meet you again to a new edition of Beyond the Cancer Diagnosis interview series. Today it's my pleasure to welcome Leslie Waltke. She is a physical therapist, and the topic of today, it is very interesting, and we'll never touch it before to our series. It is about cancer rehabilitation as an important part of survivorship care. Leslie, welcome. Nice to have you.
Thank you, Dr. Adrian. It's a pleasure to be here.
To begin our interview, I guess the audience would like to know what exactly means rehabilitation when we are talking about cancer and cancer care, and if this term rehabilitations can be used only when we are talking about survivorship care or during the cancer care treatment.
Okay. Well, that's about 10 loaded questions. That's awesome. Well, first of all, I'm going to say that we always talk about evidence-based care in oncology, right? So all rehabilitation is evidence-based. So medical oncology care that doesn't include rehabilitation, is it really evidence-based? Because a lot of programs are not using it. So I'm going to just start by throwing that out there. So what if a rehabilitation specialist's role, whether they're an occupational therapist, physical therapist, or speech and language pathologist, is we treat or provide evidence-based treatments for the cancer-related or treatment-related physiological, integumentary, musculoskeletal, movement, and functional issues that people have once they start going through the treatment cycles. So we know that surgery has a side effect profile that's amenable to physical therapy. We know that chemotherapy has a huge side effect profile that is amenable to physical therapy, as does radiation. So to wrap in another answer to your question is we want people to begin rehabilitation peri-diagnosis. We don't want to wait until they're trashed until now let's start physical therapy. We wouldn't do that with somebody who had a stroke. We don't let them lay there for 3 months and then say, maybe we should do something. We begin right away. So early mobilization in cancer care is just as important as it is in neurology and orthopedics. So we want to get a physical therapy consult as soon as possible. And depending on what treatments somebody have, how they respond to those treatments will indicate then how much physical therapy does somebody need, when do they need it, right? So we ask our referring providers, whoever is going to treat the patient first, whether it's the medical oncologist, the surgical oncologist, or the radiation oncologist, get that person to us right away. So we can develop programs to, if somebody has post-surgical problems, we can treat those problems, but we can also do anticipatory care. So if I know my patient who's recovering from lung cancer surgery has chest wall pain, difficulty breathing, they're going to start. So I'm going to treat those things. However, if they're going to be starting chemotherapy in 4 weeks, I'm also going to be preparing the patient for that. So yes, my person with lung cancer is going to be on the leg press machine. They're going to be doing squats and lunges because, again, we know that people who are exercising regularly during both chemotherapy and radiation have better outcomes. They have less fatigue, less pain, less weakness. So in a nutshell, that's kind of the roles and responsibilities of a rehab therapist in cancer care. So starting from the beginning and then following, you mentioned survivorship. Problems don't stop when the patient finishes their last day of treatment. So again, on an as-needed basis, we follow patients into survivorship, again, continuing to make sure that they're being compliant with their exercise routine. We know that exercise we call it the fourth treatment, okay? It is powerful in reducing all-cause mortality, cancer-related mortality, and certainly all the morbidity issues that people are dealing with. And so making sure that the patients are continuing to follow those programs, addressing things that may come up in survivorship, like radiation fibrosis, osteoporosis, pelvic floor issues for men and women, depending on what kind of surgery they had, ongoing fatigue, ongoing neuropathy, aromatase inhibitor pains are huge. And again, that's our job, is to deal with and treat those things as effectively as possible. So it's a long road. We follow the patient from the beginning and just stay by their side and interject as needed when needed.
Here I would like to make some, let's say, observations first. I understand that it is an important part of multidisciplinarity and the multidisciplinary team of cancer care. And the second one, it's like we try as psycho-oncologists to, let's say, to find or to talk with the patient pre-diagnosis, then during diagnosis, and then post-diagnosis. More or less is the same thing, because also our aim is to it's better to have a discussions with the patient when we receive the diagnosis,
right?
Because it's much easier after, because we know with what we have to deal further, and this is the same for rehabilitation.
Yeah,
because rehabilitation starts before the rehabilitation.
And I can see the parallels between rehab and psycho-oncology, because it is the greatest part of my day. So somebody has just been diagnosed, they have met their med-onc, rad-onc, surgical oncologist, and it's heavy, right? They have to make big decisions on sometimes very little information or stuff that they just can't comprehend because they don't know it. And then, and certainly treatments that are going to take quite a while and could have profound effect on their life and their function. But for me to walk into that room then and say, hi, nice to meet you. And I'm your oncology physical therapist. And regardless of what your physician team needs to throw at this cancer to get it out of your body and keep it from coming back, I'm going to be by your side, making sure that you stay strong, healthy, mobile, functional, and then keeping you as strong as possible, as fatigue-free as possible. And then once this is done, we get you back to healthy, happy, and strong again as quickly as possible. That for a patient right there, they smile when they're like, wow, that's incredible. So it really sets the trajectory of a healthier, less stressed cancer patient. When you can say, yes, we're sorry that we're going to need to do surgery, chemotherapy, and radiation to you. However, we're going to support you with these extra evidence-based treatments to make sure that that you stay healthy and strong. And what's nice too is our physicians appreciate, because a stronger, healthier cancer patient is less expensive. They go to the ED less often, or the emergency department less often. They get readmitted to the hospital less often. They need fewer narcotics. They fall less. So a happier, healthier cancer patient is good for the patient, obviously, but it's also good for the medical team and the health system. So it's a really nice win-win. But again, setting that seed at the beginning, when you tell a cancer patient, listen, you're going to be exercising and you're going to be lifting weights. And again, whether they're 90 years old or 20 years old, we meet the patient where they are, and we can adapt a program to match their needs and their desires and what they have access to. But you're going to be exercising. We're going to keep you moving. And they're like, wow, that just sets a tone for not only the patient, but the entire team. And it's just a wonderful part of comprehensive cancer care to be able to provide that to the patient. It's the best part of my day.
And to continue this, what you mentioned, the things that are common between psycho-oncology and rehabilitation, we as psycho-oncologists, we assure the patient that they have time, like let's say philosophically more than and practical, which is not an easy job to do, then to build hope. And we are talking about, let's say, emotional part, and then you come with the physical part. You gave them trust that yes, you can walk again. Yes. If you follow what I'm going to tell you, it will be okay for you at the end. So we are on the same patients, but on different.
The studies are clear that obviously when you look at the fears of people just newly diagnosed. Obviously, the fear of death is huge. It's usually number one. But a big one right behind that is the fear of disability and the fear of loss and the fear of not being able to who they are and losing their jobs and whatever, and losing their functional health and who they are. That's number two usually. And again, to be able to step in and address that immediately off the bat is pretty cool. And make sure that that doesn't happen. We can't always fix everything, but we can certainly make everybody a little bit less weak, have less fatigue, less neuropathy, less pain, less weakness. That's a good thing.
To move forward, you founded an academy, Waltke Cancer Rehabilitation Academy. Could you tell us the missions, values that
Sure, I would love
guide
to.
the academy from the beginning
So
till now?
why this happened in the first place was, we all see the world through the eyes of our own profession, and we're very focused. I mean, cancer care is very siloed. Everybody has their own piece of what they do. But what's happening is that most physical therapists in school get very little on cancer. And when our physicians and nurses go to medical school, they get very little on rehab. So we have fabulously brilliant oncologists that don't know what physical therapists do, and fabulously brilliant physical therapists that don't know everything that a cancer patient goes through. So that's what I call the cancer rehab gap. And that's why I developed the academy, is to teach physical therapists, occupational therapists, how to take care of a cancer patient. What do you do? What do you look for? What do you evaluate? What's your physical exam? What's your treatment protocols? How do you progress and regress based on their treatment response? And then I also then teach to and lecture to physicians, nurses, nurse practitioners, pharmacists, all the other people again, so they understand the true depth and breadth of what a physical therapist can do for their patient. And what's nice is not only is, like I said, it's good for the patient, it's also good for the medical system. So when I can say to a physician, listen, we're going to decrease the patient's fall risk, they're going to need less medication, they're going to complain less, they're going to go to the hospital less often. Those are all really good things. So typically a good physical therapist can make a physician's life much easier. So it really is a nice win-win. So that was kind of the gist of why I started teaching. Plus, I love doing it and teaching to physicians and teaching to nurses and social workers and genetic counselors and researchers and nurse navigators, as well as physical therapists. They're just people that are there because they care and they want to learn. And again, it's such a win-win area of healthcare that it's fun to teach.
You mentioned the values of the academy, but your personal expectations are fulfilled now after all these years with the academy, or do you think, or do you feel that it is something a little bit that you have to accomplish?
Yeah, I'm not done yet. So, when I look at specific mission, I would say that my mission, or the mission of cancer rehab, is to ensure that our patients with cancer achieve their highest possible both medical and quality of life outcome. I mean, that's kind of the mission. Why do we do this? And the vision is that eventually that every person diagnosed with cancer, regardless of age and gender and type of cancer, or where they are on this beautiful planet, that they're offered a high quality cancer rehab consult and then treatment when indicated. So that's the vision. So what do I want to do? I am 60 years old. I'm looking at the end of my career as a full-time clinician in the next years, probably. I am planning now to do a lot more public speaking. I want to do more teaching, again, to take this concept and bring it to the masses, to make sure that all of our physicians and nurses and physical therapists and physios can maximize their skill set in helping our mutual patients. So I want to keep teaching. I want to so badly, and I love so dearly talking directly to patients. So I do a lot of public speaking directly to patients, because again, they don't get a lot of this information, and to be able to just speak for a while and make significant changes is really cool. And I am a debut author. I've got a book that's going to come out in hopefully the summer of 2027, and it's called After. And it is specifically for people who have finished their primary treatment for cancer. So surgery, chemo, radiation is done, and then they get kind of dumped off of our pretty aggressive treadmill of stuff. And then all of a sudden they're like, what do I do now? I still don't feel good. I'm still weak. I still have fatigue. My feet are numb. How do I do this? I'm having these relationship issues and I got to return to work and I'm supposed to be able to stay up and take care of the kids. And I can't remember anything. So they still have issues. So that's what this first book is. It's titled After. And it is specifically for that. Yeah, is specifically for the people that have just finished treatment and now are stepping into survivorship. Like, here's your kind of guide. And then I will eventually write a book called During, which is for people who are newly diagnosed with cancer. And then I'm planning on doing one as well for patients. For support people, caregivers. And that's going to be alongside is the name of that book. And then again, certainly addressing our patients that have metastatic or chronic cancer. And I'm also going to write a book for people that have genetic predispositions or at high risk for cancer. Because again, that's another group of people that is really getting a lot of attention and a lot of treatment now that doesn't get any support whatsoever because they don't have cancer. But they're making big decisions and sometimes having very big surgeries. So I have a lot to do yet.
Future plans. You mentioned something which is true and very interesting. There are a lot of gaps still within the oncology, even though we are on the same domain. There are still gaps, and over this 30 years career, which is impressive in rehabilitation. What is most difficult to do to reduce this gap, to build, to coordinate, or to integrate cancer rehabilitation programs? Because there are three different things.
Yeah, there are three different things for sure. And what I do right now is I coordinate one of the largest cancer rehab programs in the United States. I would say that I think that building and integrating are actually combined. I think you have to do them. They're two different things, but I think you have to do them both at the same time. Otherwise, you can spend a year building a program, but nobody's sending their patients to you because they don't know you exist. So I think simultaneously, we need to teach our rehab therapists, okay, cancer patient A comes to you, this is what you do, this is how you follow them, and so forth. These are the treatments you can provide. Here's the manual therapy techniques. Here's some therapeutic exercise that you can use. And then, but at the same time, you have to begin to integrate. I need those therapists to know who the radiation therapist is. I need them to know who the cancer dietitian is, the medical oncologist, the radiation oncologist, and the surgeon. They need to know these people. And then these people on the medical side need, again, to know what it is that our physical therapists can, that the value that they can provide to the patient and to them. So that has to be kind of simultaneous, or at least a piece of both of those at the same time. And then it just does take, once that kind of, you get the ball built and then you get the ball rolling, then the coordination piece. You're always going to need a champion on the rehab side. You're always going to need a champion on the medical side to make sure that, process improvement and the flow of referrals and all of that stuff continues to go well. And we are practicing at the top of our license and making sure that our quality is consistent and as high as possible. So that will always take coordination. But I think that the base of that pyramid, again, is program building and program integration. They're both there at the bottom.
You said that now you coordinate the biggest program in the US. What are the main challenges also for this program? The biggest one that for sure you face a lot of challenges. And also during this career, what did you find to be the most common challenges and also opportunities? Because I do believe as a specialist that when we are talking about challenges, for sure there are opportunities as well.
Yep. I would say probably the biggest barrier, which is why integration can't be done, or building can't be done without integration, is that physicians and nurses are so busy. They have such a huge caseload. They have very little time. They have a huge checklist to get through. And so that's issue number one. And I don't think that that's going to go away. Issue number two, again, is they just don't have a good sound background in, again, the physiological, cardiopulmonary, integumentary, and functional and movement issues that we can help with. So the biggest barrier then is getting somebody to, or they'll say, oh yeah, I understand it's really good for people, but they go back to their clinic and see 30 patients and they don't refer one of them because it just isn't in their brain to refer to rehab, rehab consult. So that is probably getting physicians to understand the importance, but then to behavior change, right? Getting those physicians then to act on it. And how each company does that is up to them. Sometimes the nurse navigator can put in the referral. Sometimes, and again, depending on where you are in the world, your system is going to be different. But it's getting patients to understand the importance and then getting physicians to provide that information to the patient so the patient actually gets to us. And the beautiful thing is that the opportunities, again, come from challenges. So that's our biggest challenge. The ability to make massive change by literally helping a medical oncology group make that simple referral, right? Like teaching, this is how you do it. This is where you write it down. This is what you say. Because we really approach it in my company that a cancer rehab consult is no more optional to the patient than a radiation oncology consult. It is that important. So how the physician scripts it is important. Because if you can tell the doc doesn't think it's important, the patient's not going to think it's important. But we know research has even said, even if a medical oncologist just says the word exercise, patients are more likely to do it. So we have a lot of opportunity to improve. And then when we do make those subtle changes, we're certainly going to see quality of life in the patient population go up. We're going to see the length of life in the population go up because a physical therapist can improve performance status. They can improve an ejection fraction. They can keep the patient healthier, happier, stronger, which means more treatment, right? More better treatment response. So that's why it's good for the whole gamut. And so the opportunities are pretty cool. And again, helpful just to the patient and to the system itself. So they're fun opportunities.
When we are talking about oncological diagnosis, we are talking about first coping with cancer. That's the first thing that a patient heard after the shock of the diagnosis, how to cope with the cancer.
Yep.
And from your part, within this cancer care and from your field of expertise, what's your view in this concept of coping with cancer?
Yeah, it's massively important. And we get sometimes, again, in some area, again, how many people get referred to rehab is very geographical, right? And sometimes we'll get arguments, oh, rehab is too expensive, or the patient's too tired, or they're too sick, or they're too busy, right? And all of those things very possibly could be true. However, if you take a patient and they have less pain, they're more confident in their movement, they have less fatigue, they're lifting weights, they're on a walking program, that is only going to support their coping skills, right? So if somebody has the ability to get in and out of the car, if they can walk to and from the bathroom or get in and out of the hospital or get up and off the radiation table without as much pain or without as much effort, they're going to cope better with what they've got. It is cancer and cancer treatment is a lot to cope with. So let's give somebody good strength, good function, self-confidence, and as little pain as possible to be able to handle all that's coming at them. It'd be like telling somebody off the street to go do a triathlon without training them to swim, bike, and run. You can't, it's not going to work very well. So it's important.
You mentioned, and I know from my experience also, cancer-related fatigue, cancer-related pain. Except fatigue and pain, what is the most common, let's say, outcome from cancer treatments that you are, or side effects that you are deal with? Because fatigue is number one, then it's pain or
pain is
pain
is number two.
Pain or fatigue is yes.
I would say number three is weakness. All right, whether at the surgical site and or just systemically from treatment. Neuropathy is I think 50% of people that undergo chemotherapy have some long-lasting neuropathy. And again, we can't always fix the sensory neuropathy. But we certainly can help people trip less, walk better, get up and down the stairs easier, be less of a fall risk. And then another common thing is aromatase inhibitor related arthralgias and myalgias. I think upwards of 30 to 40% of people that are on those medications they stop because the pain is too much. And there is clear evidence, and I see it all the time, that we can get people walking, again, regardless of age, regardless of gender, or just overall health status. If we can get people walking and moving and doing simple things like sit to stand from a chair or push-ups against the wall, that dramatically reduces that AI-related pain, and therefore they can hopefully stay on those medications better or longer or with less discomfort. So that's a big one as well. And then we do see people, with pathological fractures or with metastatic disease that are going to be on treatment for the rest of their life. So they need to make sure that they are, they're not a fall risk, that we are keeping their legs strong, their left ventricle nice and strong, so their ejection fraction stays up. So there is a really large depth and breadth of the type of patients that walk in our doors. Some people just need like soft tissue work after, a year or two after radiation's finished. That's when the tissue starts to get tight. And people are like, I can't bend my knee, or I can't get my arm over my head, or it just hurts. So we do a lot of manual therapy as well, getting our hands on tissue and just either lengthening it, like after a mastectomy, where it's just so tight that you can't get your arm over your head, and or mobilizing tissue after radiation to make it softer, more pliable, longer, so it hurts less when it moves, and the body just moves better. So there's a ton of things on our plate that we can do, both in treatment and in survivorship, and even end of life, to help people live as best possible.
We are approaching the end of our interview, and I would like to ask you final questions that I love to ask my guest. It is about a statement that said that too much hope is a false hope. You work with hope every day. Your hope for the patients to improve. Patients work with hope just to be better. Is too much hope in your field false hope, or it is what is needed when we are confronted?
Yeah, only a psychologist would ask that question. But it is good though, right? I think because hope doesn't pay the mortgage, hope can't change the weather, and hope certainly can't cure cancer. And what I really dislike is when the toxic positivity. You're not just trying. You feel bad because you're not trying hard enough. You're not staying positive enough. If you would have worked harder, your cancer wouldn't have come back, right? That is very toxic, very negative. And we certainly don't want hope to be a negative. But I think too, though, that hope is intrinsic to both vision and to growth. When you say to somebody, what do you hope for your cancer program? Like, well, we want to double our volumes. We want to make sure that nobody in the city that goes without cancer care. We want to make sure that we're providing the best quality of care. And so vision is based on hope. Like, what do we want? What do we hope for? And that's a question I ask patients. It's like, what do you want? How do you see yourself getting through this? And when you're finished, how do you expect to be? Because I think people with cancer, not everybody, but it's kind of this unknown or unspoken, like, well, I have cancer, so I'm going to be miserable for the rest of my life. I'm broken. There's something wrong with me. And even when they're cancer free, I think they continue to hold that on their shoulders. Like, there's something, I am damaged. I had cancer surgery. I'll never be okay. And that, so much of that is not accurate. And that's, I think, where that hope and vision comes in. So hope can be negative, and hope can be great. You just have to make sure that you're using it in the right places with the right context.
Leslie, thank you very much.
It was my pleasure, Adrian. Thank you so much.
For being with us today. Thank you so much for the insights that you mentioned. Very interesting, and good luck further, especially with your books. Really,
thank you.
Look forward to reading them, and good luck further with the Academy.
Thank you very much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.